right. Hello, everybody. Thank you so much for joining us today. I'm so excited to be co-presenting with Rebecca Lanquist. We both have worked really hard at getting together all this information regarding to code or not to code. We know that that's a very important decision for digital health technology startups. And we're just excited to dive in. We have a lot of information to go through. So the agenda today, we'll briefly cover the learning objectives. We'll cover brief introductions about our backgrounds and why we're qualified to talk about this issue. And then we will dive into the traditional reimbursement pathways as well as non-traditional reimbursement pathways and what that means. The learning objectives for today are really to understand the role of reimbursement codes and digital health tech for securing payer contracts or enterprise contracts in general. It's about gaining clarity about the various reimbursement pathway options for your specific solution. We worked on creating a framework that we think could be very useful for you to sort of at least get you started. And then as well as just really understanding what kind of pathways are available for you. And we'll share some real life case studies with you. If you have any questions, please feel free to drop them in the chat or raise your hand, and we will make sure to answer that. We have Q&A time at the end of the presentation as well, where we'd love to just kind of have your questions as well. But if there's an important topic, we can absolutely take a pause and address your question as we're going through the slides. With that, Rebecca, I will pass it on to you for your introduction.
Thank you so much, Demi. So my name is Rebecca Lanquist, and I am the Director of Reimbursement Consulting and owner of Horizon Reimbursement Consulting. I've worked in the medical device field for 20 years, specifically most of it on strategy for new medical devices and technology. I've worked for 2 consulting companies. I have worked for several global medical device companies and even spent a little time as a home medical device billing manager. So I've kind of been on the full spectrum watching devices commercialize, and most of it is actually been through truly helping new devices get new codes and assist in the commercialization process. So I do understand a lot of what companies go through, and I've worked with a variety of situations and specific to digital health technologies. So I'm very excited to speak more. At Horizon Reimbursement Consulting, we specialize in trying to give you practical takeaways. And so just to give you a little bit of some, and maybe okay, there it goes. Some ideas on the process itself is really understanding how reimbursement and market access is integral for the commercialization process. And so when we talk about reimbursement, we're really talking about 3 different aspects that are integral in achieving success. And so we talk about coding, we talk about coverage, whether the product is covered for a certain patient population. And we also talk about payment, which is associated with the coding and coverage. That's kind of your traditional pathway. When we talk about market access, that's a terminology when we talk about patients being able to access your technology for all the patients who would benefit, and that they get rapid and maintained access at the right price. So when we talk about market access, that really encompasses more such as real-world evidence, health economics, the claims that you're making, any evidence that you're presenting to stakeholders, and it could even go as far as patient advocacy, outcomes, value propositions, just to give you an idea. So we'll talk, we specialize in both, from concept to adoption. And there are different steps to this process just to be able to be successful in saving time and not having really being targeted in your launch cycle. Next slide. So what does that mean? Really, at each stage, we can help not only with coding, but also evidence generation and perspective of payers, because each process builds on itself. So sometimes in a practical sense, that means reimbursement tools, such as reference guides, educational webinars, but also plans to engage payers. So I'll hand that over to you, Demi.
Amazing. Thank you so much. Um, Brief overview of me. Some of you already know me. A lot of you are new to who I am and what I do. I am CEO and Chief Strategist at Akros Advisory Services. I spent a decade within the strategy, innovation, business development space. In my last few roles, I was Director of Strategy and Business Development at United Healthcare, Executive Director of Innovation within United Healthcare Community and State. I have worked across Medicaid, Medicare, commercial populations, and really thinking about how to diversify the benefit set, really helping the company rethink the definition of benefits and what does that mean. And so in my roles, I've oftentimes really had been challenged to work on the two ends of one spectrum around innovation. On one end, work with really disruptive, innovative startups, and the other end, work with very large organizations that are playing in the space of convergence. For example, Apple, technology company, getting into healthcare, or Walmart, very large retailer, getting into healthcare. I really enjoyed working with startups, so I decided to make it my mission, and created Akros Advisory to really help startups accelerate their time to market through more effective partnerships with large organizations like peers, providers, employers, and as a result, have had the opportunity to work with a multitude of Techstars companies as an entrepreneur in residence. Also, I have won the award of Mentor of the Year for the work I was doing while at United Healthcare, in my ability to be able to launch pilots with startups much quicker and bring their solutions to market and provide that access to our membership. So I really, really love this work, and I'm very passionate about the space. And so that's kind of what led us to here today. This is the question that I get all the time, and so Rebecca and I have come together to really provide more clarity around this question. So Rebecca mentioned medical device, and she definitely has that experience. I do not. And so I want to just clarify the space that I cover. Specifically, I focus on software, digital health tech, and I really like to help companies where there is no traditional reimbursement pathway available. So that is my sweet spot. I like to get in and get really creative and really find the ways to get reimbursement without having that traditional reimbursement pathway. What do we do at Akros? We really help bring your product to market faster. Time is your most valuable resource, especially in the early stages. And so that's our mission, to give you more of that time, and really help you, one, build that tailored, customized playbook, but then also help establish and initiate those right connections for you. Um, uh, right as you're starting to kind of validate and begin the work to land some of these contracts. We do have two separate offerings. We have expert classes where we capture and partner with industry leading experts to really build tactical, practical, the know-how, and give you the navigation behind how do you get to, a provider contract, a peer contract, an employer contract. What does that look like? Really equipping you with the templates and tools that we as experts use. And that typically is earlier stage companies, so pre-seed, seed, sort of take these master classes to ground themselves in the fundamentals, and they can fully go ahead and execute on the plans themselves. But oftentimes we end up working together as there's more customized needs that we need to address. And so our second offering is the advisory services, where we partner with you and really guide you and build you a custom playbook, and then provide you with the industry insights to really help maximize your chances of success with the work. What differentiates the academy from the advisory services is really the level of customization. So when it comes to these type of workshops, we typically answer very generic questions such as how long is the peer cycle, or can I have any peer customers if I don't have any customers at all? And then the master classes get a little bit more tactical around, what are mistakes to avoid, or how do I speed up the contracting process? And then the advisory services really help answer very specific questions to your technology. So if you're a Parkinson's solution, we can dive in and provide you very specific guidance there. Um, we have a master class on selling to peers that's available right now, and we are giving $500 off of the fee for this class. So if you're interested in signing up, we cover the pre-sales, the sales, and the post-sales process. And I'm partnered with a sales expert who, for multiple decades, was on the digital health tech side selling into payers, and I provide the perspective of the buyer and what they're looking for in that transaction. So with that, I'm going to pass it to Rebecca, and we'll dive right into to code.
So I love this topic. Obviously, my position is in to code or to not code is first actually looking to see if your technology has a code. And so I'm going to just dive into a little bit of what we first started out with. In reimbursement, your coding, coverage, and payment is so interconnected. One is basically related. And so, for example, with codes, it is the common coding language that is really going to determine the payment. And so I'm just going to give a brief example here. So if we take an ophthalmology example where someone is providing a service or procedure, we are documenting that procedure, the medical necessity, if it's reasonable. And then from that service, it is defined as a common language, typically with CPT codes and ICD-10 codes. And that is actually being what's put on the claim. The claim is submitted, and then it is either processed for payment or rejection, with the ability to appeal. So this process takes time, and it's very, very regulated in that it's a very compliance-oriented process. Next step. So just to get a little idea of what we're talking about, it is systemized, but it is based on different settings of care. So we have your HCPCS codes, which is called the Healthcare Common Procedure Coding System, and it is defined as level 1, level 2, and level 3. Level 1 is for outpatient professional services or procedures. That's basically called CPT-1. We also have specific proprietary lab analysis. For HCPCS level 2, that is primarily medical device or supply, ambulance services, a biologic, anything done, a service in a clinic or outpatient setting. And then we have level 3 HCPCS codes, commonly referred to as CPT-3. Those are temporary or regional codes that are limited use, that have the ability to be permanent codes. And of course, we have your ICD-10 PCS codes, which are inpatient procedures, outlining what types of procedures are being done. And then we have your ICD-10 CM codes, classification of diseases for all diagnoses, and your national drug codes. So you can see that there is systemized per actually the settings of care, but each coding set is managed by different owners. So that can add to the complexity of coding when we talk about traditional reimbursement pathways. So I love this topic. I love the conversation on reasons to code, because it's a conversation typically that's being had around raising capital. And we really do want to define if the technology has an applicable code, if there is a service, if there is a piece that is doing something. So very identifiable conversation. And it is kind of where if you fit into the traditional funding piece, insurance companies will reimburse a provider or hospital based on fee for service or a bundled payment, but it's all based on those codes. So the biggest thing on a reason to code is you really want to rule out if you do fit into the traditional funding pathway, because it could come up again and again. If you're approaching hospitals, it'll be on the paperwork to see, to basically get in and to speak to someone. If you are in the outpatient setting, providers will ask you again and again if your product has a code, because that's what they're used to and that's the language that they speak. So you want to be educated so you can speak to that. Also, argument 2 is, do you warrant a new code? Is there something being provided that isn't currently defined in our system generically? It could be a opportunity to be differentiated as a new code. Number 3 is just because codes inform payment. While you might not be applicable to a specific code, there's still, in a sense, a relationship there with your stakeholder in the payments that they're receiving. So your model, your business model, may be influenced by the payments that the hospital system is receiving or the provider's receiving. And then just number 4 is the lovely nuances of reimbursement and market access. Is there may be rules associated with codes and the way that you design your product that basically where you need to know, and that's going to basically support your product and commercialization. So we'll talk about an example specific to argument number 4 in the following slides. But I just want to give you an idea. This is very a theoretical slide, is that if you are determining whether your product has a code or is applicable to a new code, I'm going to just give a couple of examples. This is not all inclusive. So if you know already that it's pretty evident that your service is providing remote patient monitoring, there's some sort of basically measurement that is being uploaded to the cloud and being transferred either to the patient or the physician, you can basically just understand the ins and outs of those particular codes and how it may be, how your providers may be billing for it. So while you might not be diving into that question of to code, you might want to seek guidance on your launch and post-launch strategy just with the nuances. to making sure that you fit nicely into that. Another example, if you are a medical device with a digital component, you might be a separate code, or you might be included as somewhat what we call under a bundle or included in another payment. So that's just a question. Is it fit into like an umbrella of a code, or is it like an app able to get a separate code? So that's still in the existing model. But when we talk about theory of potentially new codes, if you are defined as a digital therapeutic to treat or diagnose, I would recommend that you find out if a new code would apply. A lot of this depends on a significant distinction. For example, in evidence, if you're trying to do something in a new way, a new treatment, a new methodology, it's worth your time to kind of explore that option. And then again, if you're just a digital medical device, but you have something so revolutionizing, or it is something where payers and the provider community at large really want to use the technology, there may be opportunity there. But when I'm talking about really being differentiated, I'm talking about in a big way. So obviously with the COVID-19 public health emergency, we saw a lot of different remote services being adopted. And so this would be something where widespread adoption is actually driving the adoption of a new code. Thank you. So in talking just a little bit about the nuances of coding, to be able to be eligible for a code, there are nuances which we kind of sometimes refer to coding mechanisms. And so this particular case study was one of those devices that would be considered a medical device, but it also had a very integral smartphone application. So we saw Dexcom first launch the fully mobile continuous glucose monitoring system quite a few years ago. But the reason why this is so important to understand coding mechanisms is kind of the process that Dexcom went through. They were so revolutionary to the diabetes management area, but they had to jump through a couple of hoops. With it being a fully mobile application where you could see basically blood glucose, basically your measuring your A1C and such, is that it was able to be put on a smartphone and a smartwatch. Private payers did cover this type of device, but the biggest limit in this history was Medicare itself. And in this home space, there are a lot of regulations. So at first, their launch device was not covered by Medicare, and it did not qualify for a code. Later on, through work with CMS, they were able to provide the product to Medicare beneficiaries, but they had to have something that would qualify it as a durable medical device. So they had an actual receiver that showed basically the information, and it was not a smartphone. And then later, Medicare ruled that you could actually receive the measurements on the smartphone or the receiver if the receiver was delivered to the patient. So there wasn't an issue depending on which type of device, which application the patient was using. So since then, the company has launched several different versions of the continuous glucose monitor, and it has done very well. So
Awesome. Thanks, Rebecca. I did want to add to this. I wanted to emphasize what you said, which was that private payers were covering this.
Yes.
And so I just want to call that out because I'm going to talk a lot about that in my section. That you can still get coverage and reimbursement, even if there is not codes for certain populations. In this instance, it was Medicare, right? That was being the difficult one. So that is what I focus on and do. And also, I want to call out another point. So this is an FDA cleared medical device, but there are a lot of solutions that I work with where we have a device component that's married with a software component, or we have some sort of device that is not FDA approved. And FDA clearance is not what we're going for, but it does support the overall solution. So that I just wanted to call that out, that you can still get reimbursement even if your device is not FDA approved or cleared. Any other thoughts, Rebecca?
No, it's just one of those things where there was a heavy lift, and it's just exciting to see something, a technology that is so impactful.
Great. Love that. Okay, well, I'll jump right into my section, just being mindful of time. And so I'll take the other side of the argument around not coding. I'm going to jump right into a case study, and then I'll kind of take my position of all the reasons why not to code. Um, so I was looking for, what's kind of a good example that I can take. I know a lot of the companies that I work with are they're developing new technologies and or new care models, things like that. So an example that I thought could really showcase multiple facets of how complex the space is the doula space. Not sure how many of you are familiar with the doula space. The thing that I want to call out here is that reimbursement can vary by the benefit type or the technology type. And so when it comes to doula services, they're considered non-clinical services, but they do support healthcare needs. So that's, I would say, the biggest piece here when it comes to reimbursement. Payers at the end of the day are financial fiduciaries, so they have responsibility to their members to manage their funds. And so they want to invest in solutions that are going to be evidence-based. Now, there is a difference between something that is evidence-based and something that is clinical or non-clinical. So I want to call that distinction here. And so we are in a time and place where reimbursement is starting to gain traction, and really establish some pathways for doula care to secure payment because of the growing evidence in the space, because of the clear ROI for doula care. Now, so reimbursement can vary by benefit type, technology type. Reimbursement can also vary by state. So in the example of doulas, you can see here in this map of the US that there is, some states that cover Medicaid and some states that are considering coverage, and then some states that do provide certain coverage. So, and then there is variation when we look at state by state by state level. So you can see here, I pulled out the state of New York, Washington, Oregon, the variety of the rates that you're getting. In some instances, you're getting $360. In some cases, you're getting 30. In some cases, you're getting $600 or more. And so there is, I know some of you are actually international companies that are on the call today. In the US, we do have variation from state to state to state in terms of the level of reimbursement. Again, this is for the Medicaid population. We also have, Medicare populations and commercial populations where they're going to have different rates for the similar procedures. To add to the complexity, then we, step into the land of payers where reimbursement can vary by insurance company. So every single insurance company can make its own decisions about what to reimburse for. So here I pulled a few examples from a variety of insurance companies. So for example, CVS Health launched a program with maternal health provider May, so they've decided to partner with that particular solution. In South Carolina, Blue Cross Blue Shield decided to partner with their own solution. Then here's an example of the new doula network projects, and they're partnered with 27 different health plans. So this one solution has 27 different partnerships across the U.S. And then on the right-hand side, I just talk about even within that one company. So in this instance is United Healthcare. They have multiple doula projects and multiple doula partnerships. So the same company could take different approaches and test this out, test a different solution in different markets to see, where it's working, where it's not, which populations are responding the most well to that treatment, where can they see the biggest potentially ROI by deploying this project. So there's no there's so many different ways to approach the space, right? But what I really help with my team in Akros, we focus on is really dissecting this whole space and having really intimate knowledge of what solutions are peers partnering with, what capabilities do they actually have in-house, so that when you're trying to figure out your go-to-market, okay, this set of companies already has existing capabilities. That's going to be really hard for us to compete with. But then there's this set of peers that don't have any existing capabilities, or maybe they have some partnerships, but the solution for whatever reason is very much subpar as compared to what your solution is. So then we figure out what is that differentiation, what's that narrative. And here's another example. So reimbursement, we said it can vary by technology, can vary by state, can vary by insurance company, can vary by employer. A very big part, 155 million people in the US get their insurance through their employer. And so the employer has the final say on what the benefit set is. And so digital health tech companies have very much seen success in um, landing employer contracts. Employers for many years have been that sort of first adopter, first mover to try out and test out new benefits. So as you can see here, Walmart has a doula benefit, CVS has a doula benefit, Microsoft has a doula benefit, and so they can decide whether or not they want to reimburse for these type of services or not, and at what level. So in negotiating with the depending on what the arrangement is. So in this instance, we were talking about very large employers who often have what we call ASO contracts, or administrative services contracts, with the health insurance companies. They get to sort of negotiate and work with the health insurance company on deciding, how they want to provide the service and the reimbursement rates for these type of services. So what this results in, continuing with the doula example, is this example where you can have multiple companies in the same space that have very different business models. So here we have Mommy and we have Ula, and we have them in two different states where they have very different, reimbursement from the Medicaid side of things. But we have very different models. So Mommy decided we're just going to have a membership, and this is going to be direct to consumer, and we're just going to charge the consumer a certain dollar amount, and then if they need additional services, there's going to be a additional price associated to that. Versus ULA, which is getting, it was in network with major insurance companies, and including getting reimbursed from the state in New York. They are also potentially getting some additional payment from the insurance companies for their solution. So all that goes to say is, given the dynamic in the space and given what your product is, there's multiple pathways to market. What I try to do and what the team at Akros tries to do is really help equip you as a leader to make an informed decision about what is the best path for you to market, and how do you maximize the value that you're bringing with your solution. And sometimes that's deciding, hey, we're going to have to start the employer route to generate the evidence that's needed to then land a payer contract, or we're going to go direct to consumer while we are also pursuing B2B type relationships. So it really depends on what your specific solution is, and what market you're playing in. So to kind of wrap all of that, top reasons not to code. There is no applicable code, so it really doesn't apply to you. Also, I mean, it takes a lot of time, and it takes a lot of money to, if you decide, yes, we want to get a new code. Rebecca, you can probably speak to this regarding how much money and how much time it actually takes. Do you want to comment on that?
Sure. It actually leads into one of our next slides. So
Oh,
do you mind if
amazing.
I wait till that
Okay,
slide?
perfect. I'll have you
Okay,
comment on that
we
then.
will talk about it.
Amazing. And then, at the end of the day, I pulled out an example here. So Allison participated in the United Healthcare Accelerator Program, which I am a part of. And, I love this example here that I pulled out where she talks about, coverage doesn't mean access. The fact that there is reimbursement, the fact that there are codes, it doesn't mean that it's actually you're going to be able to make enough money to where it makes financial sense for your business. And so that might actually not be the best option for you in terms of maximizing the value for your particular solution. So that is my final argument. Rebecca and I were thinking a lot about this, like, how do we make this process easier for you? So we decided to pull together a series of sort of decision making or steps, and sort of an assessment for you. So we'll cover that in this next section here. Rebecca.
Sure. So the steps that, if we were to simplify this, is really to rule out existing codes. If you're a Me Too product, if there are products already on the market, there might be situations where it's just obvious. It's obvious that there might be not a specific code that applies. So in some situations, you might need just the due diligence just to rule that out. But first, rule it out to see if you're a Me Too product or something that would qualify as what we would call just maybe an alternative or non-traditional funding route. So second, it's really your kind of decision. So obviously you have the opportunity to consider if there is a new code that would be applicable. With this, that does take significant funding and a significant timeline. Of course, as we mentioned, there are different types of codes. Some codes can be fairly quick, but each code is based on evidence. So if you are talking about, for example, a CPT-1 code, depending on your evidence, just kind of considering the time that it takes to gather evidence, you might be looking at roughly 3 to 5 years, but it all depends. You might fast track it because you know exactly the evidence that's going to be relevant to the stakeholders that would be supporting your coding application. In the HCPCS area, again, evidence is key, depending on different factors. So it depends. So some companies have still been trying for a new code after 10 years. So like Demi had mentioned, and also that is a long process that you want to know what was involved and if you want to go that route. Sometimes, because just of the system, you will have to potentially go that route, but that's where it's just good to have that conversation up front so you know where you're going. And obviously, the other alternative, always analyze your alternatives. And that's really, again, based on the unmet need of your technology, based on market research, clinical need, impact, meaningful data, that really may be the foundation of what types of options are available. And I'm sure, Demi, you can maybe even add a little bit to that. So please add if you'd like to.
Yeah, that's great. I mean, uh, again, we're just trying to put our brains together. How do we make this simple for you? Can we just give you some sort of framework to work off of? So this is at a high level, kind of the process that we would recommend that you undertake. And of course, always having an expert or validating, or maybe you decide to do this research on your own and then just go ahead and validate it with an expert. So that's, that's at a high level. Regarding, the alternative options, there's just so many. So one, I think, is being aware of what the options are. But then the bigger question in my mind is prioritizing those alternatives. And so really being able to know intimately, okay, which one of these options is going to maximize my value for minimal, investment and time and effort and things like that. So, and we can definitely help provide clarity around what it would take regarding the various routes. So here's a brief assessment that we sort of pulled together. Again, this is not an exhaustive list, but this is, I would say, a foundational list of kind of questions that you can go through and assess your own kind of company and determine what is that best next step for me to take. So, Rebecca, is there an example that we wanted to kind of walk through here? Anything that's coming to
Um,
mind?
I'm not sure, but each of these really showcases, in a sense, a continuum of whether or not um, you're gonna have certain codes or certain certain opportunities. So it's not like you check one box and you're automatically in or out. Um, but each of this actually builds on the picture of options.
Absolutely. And then again, at a high level, there's the traditional funding model, but there's also a variety of alternatives. So, we just wanted to clarify that if there is no existing code, there are options. Don't get discouraged. There are many more options, and that was also the point of the doula case study that I wanted to use, is to say, in some states you may have an amazing opportunity financially, it makes sense to code. In other states not so much. So it depends geographically, where do you want to go, and what's the most beneficial for your go to market strategy. But also, who are the right partners? Are there certain employers, are there certain payers that can partner with you and create a much more financially sustainable business, rather than trying to get codes in a space that's still emerging. Do you have anything else on this slide, Rebecca?
No, that's a great summary.
Great. Well, and I know we only have a few minutes, but I really quickly wanted to, if I don't rave about us, I don't know who else would. So the top reasons to work with us, I would say one of my favorite things is to work with international companies that are expanding into the U.S. and really help guide them in crafting their go-to-market strategy. There are global differences, and sometimes it's actually much easier and faster and better to go to market in other countries than it is in the U.S. And so I studied at the London School of Economics with a particular focus on financing health systems. And so a lot of international companies just love working with me because I oftentimes understand what type of economic infrastructure they came up through, and then also be able to communicate how the U.S. is similar and or different than where they were able to kind of first launch their product. Also, we're experts in really understanding the the payer differences, the payment differences, what are all the different routes. This is just an example within the Medicare space. So again, there's commercial, there's Medicaid, and Medicaid varies by state, commercial varies by company. So we have these sort of frameworks, we have these pathways mapped out so we can very easily and a lot more quickly tell you what your alternatives and options are than if you simply try to do this on your own. I am of the opinion that the current sales cycle of 18 to 24 months and getting reimbursement, a big part of that is simply hiring people on board that like don't really understand how the process works, and so they're learning on the job, or trying to sort of operate lean, have a scrappy team. And I understand that there's financial pressures, but from a cost benefit analysis, hiring an expert that knows what they're doing and can really quickly help you assess what the best next step is actually a lot more beneficial than just trying to scramble and navigate a very complicated system by yourself. Also, the reimbursement landscape is changing. And so we're always on top of, what's the latest, greatest thing. These are just a couple of case studies that I wrote in partnership with the University of Minnesota about how, how telehealth coverage changed for a variety of companies during COVID, as well as another one on infection treatment, hospitalization treatment coverage, and cost sharing and what that looked like. And you're all familiar with how telehealth, for example, as a space evolved through COVID. So we're constantly seeing spaces like this where there's massive changes happening. The doula space is another example where there's been massive changes. Same with AI. We're starting to notice a lot of changes happening in that space as well. So all of that goes to say, Rebecca and I, working together, we have complementary services. Maybe you're in a point where you're just kind of like, is there existing codes? And so you want to start with an assessment and working with her. Once you figure out that there is no codes or that the existing pathways are maybe not as timely or a lot more costly than what you imagined, you work with me, and then we help to find other quicker, better alternatives for you. Rebecca, any additional thoughts here?
Yeah, I would just say that I specialize, and sometimes I bring on other experts to leverage what we plan to do. But anything that would be considered a physical part that would be considered a medical device or a service, if you think you have AI technology built into your offering, and then, well, we don't need to get into the nitty-gritty of RTM or RPM codes. I would say that there's a lot of tools that maybe we would want to discuss to help with launch plans.
Yeah, awesome. So now we will dive into Q&A. I really quickly just wanted to say we do have a couple of other workshops coming up, one next week, which is on ROI and how do you communicate and quantify the value of your digital health technology. So we'd love to see you there. That is a big, another big challenge that I see in the space and I constantly get questions for. So we actually are walking you through the methodology of how to calculate the ROI for your solution in this session. So very valuable. And then there's another workshop coming up on really helping you equip you as a leader with a framework around how do you make decisions of, do I hire a full-time person or do I bring in an expert or a fractional leader? Both Steve and I have worked in a variety of those roles, and we talk about the different cycles of a startup and what the timing for those would be. So we'd love to see you at this one as well. With that, I will open it up to questions. Feel free to raise your hand, unmute, and I will stop sharing here so we can see your faces if you want to get on camera. No questions.
Hello, Richard from Active Insights in the UK.
Hi.
I assume there's a list on the internet of the different codes, so you can actually look to start off with to see if you potentially fit into the codes. Is that right, or is it something more hidden?
So sometimes the codes are easy to find on the internet. It is a lot easier to have a software. The caveat with that is even if you fit the coding language, that it makes sense from just the standard person's perspective, there might be nuances where you might not fit in some cases. So it is kind of like a double-edged sword. You can find certain things, but it is easier having, like, for example, a book or a software to really do a wide search because there's so many different codes. So that's a little bit of it. It can be nuanced.
Yeah, great
Okay, thank you
question.
very much.
Mm-hmm.
Any other questions? I mean, I could add to that too, in terms of saying that there is no guarantees. So there may be codes that exist, but then, you know, where you want to be really careful is recommending that like certain codes are used for billing or guaranteeing that there's going to be certain level of reimbursement for certain codes especially when working with provider systems. So there's a variety of legal regulatory you know, things to just be careful there.
And I will even add to that, like sometimes when you're just getting to launch, if other competitors think you don't fit a code, it could create a bit of a mess. So you want to have it kind of checked out in some senses. Like you mentioned, Demi, there's the regulatory part to it, there's the legal, and what we call just the compliance, just because people can get in trouble for doing something in a uncompliant way.
Great. Julius, do you have a question?
Yeah. So thank you for
Great.
this. It was great. Do either of you have much in the way of experience with the remote therapeutic monitoring codes, specifically for mental health and like how it might apply to, say, cognitive behavioral therapy or something like that?
We both, in a sense, do. So that is an emerging area that is exciting. Obviously, there are codes for a company called Paratherapeutics. You know, that is a space where in who knows what it will look like in a couple years down the road. So I would answer that, the short answer, yes. There's just more though to just talk about than just the codes.
Yeah, absolutely. And I would say definitely I've worked with a couple of clients in the mental health space and familiar with that. So happy to grab a consultation or time with you to be more specific. Luis, I see
Great, thank you.
thank you. You have your hand up.
Yes, thank you. Yeah, Luis, also in the UK. For us outside of the US, could you just explain very top level the difference between Medicare and Medicaid, and are they at the federal level, are they at state level? How do they work within the different states and so on?
Oh boy. Okay, that's
Very
that
top
might
level.
take me I was gonna say that might take me a few weeks to explain. But yes, so Medicare is for folks that are 65 plus. So we're talking about seniors, and so it's a whole different population. Medicaid is typically meets certain federal poverty limits where that population basically cannot afford their own coverage, or it doesn't come out of an employer's paycheck, or etc. And so that is a key distinction there. Now it gets really complicated in the space where the two merge, because there's a population that we call duals, where these are individuals that fit into the requirements around, you know, poverty levels, et cetera, but they're also 65 plus, and they also have additional complex conditions. So typically those patients are paid for by the state, so by Medicaid, but then the benefits are administered to Medicare. So there's a lot of complexity in that space. I actually love to work in that space. I work with multiple startups in the what we call the program for the all-inclusive care of the elderly, where it sort of plays in those type of individuals. So, and I have an Excel spreadsheet that I don't even know how long it is, where it maps out all the various reimbursements from all the way from Medicaid to Medicare, and then where the two merge in the middle. So it's complex, but so Medicaid is paid for by the states. In some instances, it is administered by managed care organizations. In some instances, the state does the administration of the benefits and the payment. So sometimes who pays and who administers is different. That's the high level. I'm going to stop there.
That's awesome. That's great.
Yeah.
Thanks so much. Really helpful.
Of course. Richard, I see your hand up.
Yeah, hi. I just want one last, in terms of experience, do either of you have experience, first of all, in codes relating to sleep medicine and the whole remote monitoring in sleep?
Yes, that's an area in the home space that I've worked in. And I have helped with a code in an alternative sleep apnea code.
Yeah.
Okay. And the other question, what about, how do codes relate when you're talking to particularly the VA, the veterans? Are they code related, or they not, doesn't really relate to them?
I was going to say, I actually work and have a VA expert that I work with, because the VA is just its own beast. So I'm happy to make you a connection introduction in that space.
Yeah, it's
Awesome.
a separate system.
It's a separate system, absolutely. Well, thank you, everybody. I know we're at time. I want to be mindful. It was lovely having all of you on, and hopefully you got a lot of value out of this conversation. We'd love to work with you, so feel free to send us an email, note, and reach out and say hello. Have a good one. Thanks, everyone.